So I just want to say thank you to all of our speakers, Dr. Krammer, Dr. Rochford. This was really wonderful. Dr. Kettle could not join us for the after the Grand Rounds question and answer session, but we're starting this as a new process this week, similar to a lot of the popular TV shows. There's the TV show, and then there's the time to talk about it afterwards. With coronavirus being as popular as it is, 900 people joined us for our Grand Rounds today. We just can't get to every question, and so we're going to try to spend 20 or 30 minutes now tackling some of the other issues. And a lot of the remaining questions are pure immunology based, but there's also, of course, a lot that cross over into epidemiology, maybe even a little bit of politics, which is, how do you get these things done on a worldwide scale? Which, Florian, I know you touched on a little bit, which is how do you get vaccines to 8 billion people is one of the questions. So I'm going to ask some of the questions myself, and then we also have our chief medical residents who can help tackle some of these questions and make this really conversational. And I just want to throw things out there that, we can spend time discussing that I think people will find interesting. The one question that came up frequently, and you had a first crack at it right before we left the big group, was this idea of drift. And Dr. Krammer, you talked about this, that you thought, things would be relatively stable. But I think we got a lot of other questions in terms of, even if it is relatively stable, will it make for difficulties developing vaccines over time? And then there were also a lot of questions regarding the infectivity and also the severity of disease. Do we expect in a virus like this, if there is any kind of drift, that's going to make it more infectious, less infectious, and how does it complicate things?
Of course, you can never say what's going to happen. It's a virus, right? We see interesting mutation happen in Singapore. Part of an open reading frame is getting lost. And that was similar to what happened with SARS coronavirus 1 and led to, at least in vitro, to an attenuation event. So we're not sure if this virus is going to make it or not. In terms of infectivity, so there's a difference in terms of the R naught and the infectivity between SARS Classic from 2003 and this one, right? And there's also a difference in affinity to the receptor, right? The affinity of the new SARS coronavirus to the receptor is much higher seen for SARS coronavirus 1. And that might actually drive the difference in infectivity and in the R naught. Would it be possible that it mutates and becomes even more infective? Maybe, potentially, but I don't think that it will really do that. It's already very well adapted to humans. We have now, 2.5 million cases officially. We probably have 5 million cases or more unofficially. There is thousands of virus sequences out there already. We don't really see that. Of course, it could happen over a longer time frame, but it's hard to say. It doesn't look like that, and I wouldn't assume, but you never know.
I'll have to agree with that. I mean, it's a tough question, but I think your point that you said, Florian, about the fact that it's that receptor binding domain, you've got that tight affinity to get inside that cell, and that puts restrictions on it. And we could go back and take the look at measles virus. There's a lot of things about measles that also maintains it's an RNA virus, but that vaccine that we use now is the same one we developed back in the 1950s. It hasn't changed. The virus hasn't changed. So we're going to hope we're on the measles side of things. It doesn't look like we're on the flu side of things because it doesn't have that propensity for the antigenic drift that we see with flu virus. So, but all we can do right now is hope that we're in one direction versus the other and look at all the sequences that are out there and see what's driving that change. There is some suggestion for more attenuation over time. I mean, the circulating seasonal coronaviruses actually came over from our zoonotic diseases and their, upper respiratory infections. So we can hope.
I think that's what a lot of people are doing right now, for sure. I'll ask one other question, and I'll throw it open to the chiefs for a few, and because it's a hope type question. Are there other viruses like SARS-CoV-1 or even others that we haven't talked about yet that don't seem to produce a long-term memory response for which we were able to create a long-term response using a vaccine?
Yes. One of the problems that we have is with old world arenaviruses, right? If you get an LCMV infection, you have usually a hard time making good neutralizing antibodies that stay. The same is true for Lassa virus infections, and that might have to do with the flexibility of the antigen. It's not true at all for New World arenaviruses. So it happens for some types of viruses. We have some data that shows a skew from IgG1 to IgG3 for the antibodies that we find with SARS coronavirus 2, which is a little bit unusual because usually you get much more IgG1 against viral glycoproteins. And IgG3 is in some ways more effective because it interacts better with Fc receptors, Fc gamma receptors, but its half-life is also shorter. And so you might end up at a lower level, not because there's less antibody there, but if you produce the same amount and the half-life is shorter, the levels are lower. So that might play into that, but we don't know enough to really kind of pin that down yet.
Fair enough. Thank you. For the chiefs, do you have a few questions lined up that you think would be interesting for the audience?
Yeah, sure. I can start. I'm not sure if this was answered previously. We were editing the document quite a bit as we were going through questions, so I'm sorry if this was already answered. But I know there were some early reports about cross-reactivity of antibodies to like the original SARS and SARS-2 virus. Is it possible that like the vaccines or the development of the vaccines for those original SARS could be used to like repurpose for SARS-CoV-2?
Go ahead.
Oh, I was just going to say, I mean, when we think about cross-reactivity, it's more in the nucleocapsid and some of the other sequences where you get cross-reactivity, but the receptor binding domain, I think, is very unique for the SARS-CoV-2 versus the original SARS-CoV-1. So I don't think we're going to get that much cross-reactivity, but I'd let Florian sort of speak to the repurposing the vaccines. I'm not sure about that.
It depends who you ask. So the CDC found considerable cross neutralization between the two. And there are monoclonal antibodies that bind to the RBD of SARS-CoV-1 and neutralize it, then bind to the RBD of SARS-CoV-2, but interestingly don't neutralize it. Mm-hmm. There is cross-reactivity. How much that would have helped is a different question. However, if we would have had a vaccine that was actually licensed for SARS coronavirus 1, it's very likely that we would have, maybe by May or June, a vaccine licensed for SARS coronavirus 2. Mm-hmm. So it might not have been helpful to use the same vaccine, but you could have just plugged it into the process, right? Mm-hmm. That's the reason why if there's an influenza pandemic, it takes a much shorter time to get an updated vaccine, because you just take whatever you're producing right now, you throw that vaccine strain out and you put the new vaccines, but nothing changes. Sometimes not even the license changes. And so if you would have had that, we could have done that. But again, there was no funding and also not the opportunity to get a vaccine against the old SARS to the market.
That makes sense. Thanks.
Deepa or Randy?
Thank you all so much for that talk. It was fantastic. I think one question, and I also apologize if it was touched on previously as we were kind of dealing with this document, but do any of you know if they've analyzed antibody responses in children yet? Differences in magnitude and response to the infection in children, and if or how we can apply this to adults?
I think that's still a big unknown. The population of kids has been so few. I mean, even here at our UCH hospital, we've just got to, there's not as many children coming in. And I don't know of any studies as of yet, and I haven't been, certainly not published. I have to look at bioarchives to see if there's something out there, to see if there's a difference between children and adults. But understanding the difference between immune response in kids versus adults is going to be pretty key. And I'll just say that in mouse models we've done with another respiratory, well, it's a gamma herpes virus, we see differences in cytokine responses between pups infected with MHV68 versus adults. And I had a graduate student worked on that years ago, and I've gone back to pull that paper out because we never published it. And I thought what's worth really thinking about age-dependent differences in inflammatory responses, how that would impact just the immunopathology, but also how it might affect development of immunity. But I don't know of any studies, and maybe Florian does.
No quantitative studies. There is a manuscript out there. There was a family cluster that was, I think, published early on in either the Lancet or New England Journal.
Yeah.
For a family in Shenzhen with ties to Wuhan. And I think there's a preprint where they made monoclonal antibodies from several of these family members. And I think one of the family members that the monoclonals are derived from is one of the kids. I remember that one of the kids was asymptomatic and the other one was symptomatic. I would guess the monoclonals are from the symptomatic kid, but I don't remember.
Yeah. But I think it's an important area to really look at the difference in immunity, what the kids are doing versus the adults, not only in antibodies, but the type, right? We talked about the isotype. And, we've talked a lot about IgG, but we haven't talked about looking at IgA and what's in the secretion in saliva and what's being shed in the mucosal sites, and if there's differences there as well.
So I have a question kind of going off from that. So I just spent a week in one of our surge ICUs caring for our COVID positive patients. And it seemed like we had a kind of disproportionate amount of pregnant women and ended up like delivering. And then we had all these questions around like, can they breastfeed? Can they not? At what point can they breastfeed? Can the baby even see the mom? Because it was always these like crash C-sections, and then the mom was still intubated for a few days. And so has there been any data, like would the child be protected if they are kind of receiving the like IgA through the breast milk?
Well, it depends on when the mom was infected, right? She could be, if it's an acute infection, she's in the ICU, she might not have even had mounted a strong response for that point. Certainly with HIV, we always encourage the moms to breastfeed, but that's for a very different reason. That's it. Wow. Yeah. There's some data coming out there about also the ability of the horizontal transfer of the infections as well. And I don't know those right now. I think those are anecdotal, not sort of published studies, but all concerning. I mean, one thing about with the pregnant women is their immune system is suppressed, right? Just as part of pregnancy, and does that make them more susceptible? And I think early on, like 2 months ago, people were saying, oh, it's not a problem with pregnant women, but I think the data is coming out more strongly that it is a problem, and certainly based on your experience, it sounds terrifying.
I think there was a lot of early data from China where women were infected and then delivered healthy babies. I think there were 2 or 3 cases where the babies were infected. Nothing really happened to them. They cleared the infections pretty quickly. We have a case here at Elmhurst right now where the baby got infected and is in pretty bad shape. So I don't know. But do you think you see something similar because during the 2009 pandemic, that was really a problem, right? That pregnant women got severely infected, right? I don't think that signal is out there for coronavirus so far.
Not yet, but I think that's one signal we got to start paying attention to.
Mm-hmm.
Yeah, I agree. I remember my the 2008-2009 was my clinical year of critical care fellowship, and so I remember at the time, and this is sort of anecdotal, of course, it just felt like there were a lot of pregnant women. You looked around and you thought, boy, this is out of proportion to what should exist in a usual infectious process. And I agree. I don't think that signals there in the literature, and it doesn't quite feel like that. Although we're certainly, these women are not immune to the staggering effects of the disease for sure. I want to ask a question that came up a couple of times about, maybe moving into the realm of the unknown, or at least continuing in the realm of the unknown, but the idea of antibody-dependent enhancement. something that may have been seen in SARS-1 and MERS, and do we think that's a possibility here?
Yes, it could happen. So, I mean, there's an in vitro study, and I didn't want to bring it up too much because I think the data is too, we don't know enough yet. But they showed in a macrophage system that you could get enhancement of infection of the macrophages. But we don't know if that translates from an in vitro study to an in vivo study, right? So does that occur in us, or is it just an artifact of cell culture? What's going on with that? Is the macrophage a good target for the amplify? In dengue, absolutely, right? So antibody-dependent enhancement in the macrophages, boom. But we don't know that much in this particular case, and that's sort of coming back to that reinfection. Our data from just the circulating coronaviruses doesn't imply that, right? So we don't have evidence in that regard. And then in this regard, we don't know enough yet to know if we're going to get reinfection. Is it going to be more severe? If it is, then that's one of the things we should really look at. But from what I can see, it's a concern, and it's a concern that's been put out there. But I don't think there's a lot of data, except for that one in vitro study I saw, to tell us that we have to worry about that in particular yet.
So I have a very strong and unbalanced opinion about that.
Those are the best kind.
So there were a lot of studies that were done with vaccines against SARS and against MERS. For MERS, there are 2 papers where there were complications with vaccines. And I don't say enhanced disease because it wasn't enhanced disease. Then that's the same for SARS papers. There was, for example, a vaccine that was MVA-based, so box virus vector, and that was given to ferrets, and the ferrets were challenged, and the ferrets did well, but there were liver issues in the challenged ferrets that were vaccinated. There were other studies where vaccines were given, and then there was more infiltration into the lung. But then if you look globally at that data in animal models, usually the animals that were vaccinated did better than the controls. So it's hard to call that enhanced disease. An important part there was that a lot of vectors, a lot of vaccines that were tried that only had the nuclear protein caused that, while if you had a strong response against the spike protein, you didn't see that. Then there is the in vitro data. There's this recent paper, but there's also an old paper, I think from Gary Nabel's group still at the Vaccine Research Center, where they found antibodies that in vitro could enhance entry. But in vivo, they were protective. And so you could also do that for influenza. There's an old Japanese paper where they have cells that are refractory to influenza infection. And if you add antibody, you can infect the cells. You can, I think, I don't know if you're familiar with Matt Freeman at the University of Maryland. He said it very well recently. It's certainly something that you can force, but that doesn't mean that it actually occurs. So that's my unbalanced opinion on this. I don't think it's going to happen. I think it needs to be studied, but
I don't think, yeah. Like I say, what you see in vitro and what you can make happen in vitro is not necessarily, you can't translate that. It's worth looking at, but probably not going to be that's not where I'm going to spend my time researching, let's put it that way.
But there's another point. So as I said, we dosed a lot of people with convalescent plasma, right? And it's compassionate use. We don't really have data, but it doesn't look like you give them the plasma and they die. They recover. They might have recovered anyways, but it doesn't seem to make it worse. And I think that's also pretty good. Well, not evidence, but points in the direction that it's not something that does seem to occur. Again, compassionate use is not a...
Right, but you are directly instilling antibodies and they're not bursting into flames afterwards.
Exactly.
Another question that came up had to do with the BCG vaccine. So a person brought up some discussion about the BCG vaccine being protective against SARS-CoV-2 and that countries that have higher rates of BCG vaccination were less affected. And we're just wondering if we could get your viewpoints on that.
See, that's not true because they have BCG vaccinations in Italy and Spain, and clearly that's that's not a problem. I mean, that's a problem there. So I was optimistic about that. I work over in Kenya and Uganda, and they give BCG vaccine. So I was thinking, oh, that would be fabulous. But like I said, the data in other areas where they have BCG vaccines hasn't held up. So, but I do know, I talked to a friend of mine in England, and they are doing BCG vaccine trials to give to people now. So it's not that it's another idea out there, and it might be, I was thinking about, well, what would it be doing, right? And one idea would be trained immunity, or if we have an immunopathology response, right, you could shift your immune response more towards immunoprotection so you don't get that damage due to the pathology. But now that we're beginning to understand more about what's going on in terms of the ARDS, and it's different than anything we've understood before, it might not be the right, we might be looking at BCG from a different perspective of just this very simplified Th1, Th2, and what we're seeing here is something completely different.
You could even play devil's advocate, because people in most European countries don't get vaccinated with BCG anymore. Only the old people got vaccinated with BCG, and those are the ones that die. So.
Yeah.
Fair enough. I think we've had time for maybe just one or two more questions, because it'll get to be 2 o'clock, and I know you all have other things to do, and I do appreciate this. The first, I can't tell if it's a silly question or a really good question. It has to do with the prevalence of this disease showing up in cats, big cats and small cats. And is that going to be a reservoir that we're ignoring, but we live alongside?
Oh, I like my dogs, so I'm fine. So, but I mean, it's clear that there are transmission to cats, right? But it could be what we sort of think about as a dead-end host, right? So it could get into the cats, but they can't serve as a reservoir for transmission. We don't know that it can move from the cats to somewhere else. So I'm gonna argue that the cats might be likely, if they are infected, they're a dead-end host and not necessarily a vector.
And, I mean, let's be honest. How does a cat get infected? If the owner is infected, that's what they found in China, right? So you're infected, you infect your cat, bad for the cat, but the cat doesn't go anywhere. Cats are not the most social animals. It's not like dogs that you walk them and then they play around with other dogs. And, I think people have to pay attention, because if you have tigers or something like that somewhere, they are protected animals. You don't want them to die from a disease like that. But I mean, house cats as vectors.
I think the rise of the Tiger King has everyone thinking cats these days alongside the SARS-CoV-2.
It's a good show.
It is a good
surprisingly.
Show. And I'll ask one last question, and this is, just you two are world's experts in this. And so if we could anoint you king and queen for the day, and you could do whatever you thought best to vaccinate, to stop this, we weren't really worried about necessarily what it would cost. What would you recommend at this point? What would be the right next few steps forward?
Developing the vaccine. I mean, that's the gold pot at the end of the rainbow, right? That's what I would do. But have it done in a 3-month window, not a 2 to 10-year window.
And is there one of those vaccine options that would be possible in a 3-month window, that could be done more quickly than others?
Not right now. I think Florian spelled it out pretty quickly. How you said, if I could do anything I wanted to and make it happen, right? Yeah. With a magical wand, that would
require a true magical wand.
I think if I would have a magical wand and I could do whatever I want, right? I would just order everybody to stay away from other people for 3 months, and that would eradicate the virus. You don't need a vaccine. The virus is just gone. But you can't do that.
Do you think, and truly, I mean, 90 days is a long time to isolate, but it's not 120 days. It's not even 360 days. Would that work? Would 90 days or something like that work to eradicate the virus if possible?
I mean, it runs out of fuel, right?
They can't get to a new vector. It's done.
Exactly.
Fair enough. Okay, great. Well, it's 2 o'clock. I really want to thank both of you for not only the excellent presentation that you made, but for spending the extra time with us. I'm sure the people who ask these questions will find it very helpful. So thank you all.
Thank you guys for organizing it. All right.
Yeah, thanks for the invitation.
Right.
Got it. Have a great day, y'all.
Right. Bye.